Hello, everyone. Welcome to Alan Hu Foundation Mental Health Lecture Series. I am Chi-Ching Hu, co-founder of Alan Hu Foundation and the host for your webinar. Today, Dr. Jami Young will present Early Identification and Prevention of Youth Depression. First off, I want to thank Mental Health Association for Chinese Communities for providing simultaneous Chinese interpretation. And thank you, Ida Xiao, for Chinese interpretation. Alan Hu Foundation's mission is to promote mental health, raise awareness, and remove stigma surrounding psychiatric disorders, and support fundamental research for cures. Please consider making a gift to Alan Hu Foundation by using the donation link in the chat box. Thank you for supporting our programs to promote mental health. Today, it is our great honor and privilege to introduce Dr. Jami Young. Dr. Young is Associate Chair of Research in Department of Child and Adolescent Psychiatry and Behavioral Sciences at Children's Hospital of Philadelphia, CHOP, and a faculty member in CHOP's PolicyLab. Dr. Young is also a clinical psychologist and a professor of psychiatry at the Perelman School of Medicine at the University of Pennsylvania. She has received funding from the National Institute of Mental Health and Institute of Education Sciences. Dr. Young's work aims to decrease the incidence of adolescent depression and increase children's access to evidence-based assessment, prevention, and treatment of depression and other behavioral health conditions. In today's presentation, Dr. Young will discuss work she has conducted over the past 20 years that has focused on the identification and prevention of adolescent depression using interpersonal psychotherapy, adolescent skills training, IPT-AST. She will explain the need for depression prevention, provide an overview of IPT-AST, briefly summarize the data from several IPT-AST studies, and share sessions learned from developing IPT-AST and conducting prevention work in community settings, including schools. Following the presentation, it will be a Q&A session. Please submit your questions using Zoom Q&A function. The presentation is for educational purpose only, and it's not intended for medical diagnosis. If you have any persistent symptoms, please seek professional help. With that, I'm going to return to Dr. Young. Welcome, Dr. Young.
Thank you so much for having me. I'm going to share my screen. And can you just confirm out loud that you can see that?
Yes.
Perfect.
Yes, it's a slideshow. Very good.
Excellent. Perfect.
Thank you.
Excellent. So thank you so much for having me today. As was introduced, I'm going to really focus today on identifying and ideally preventing youth depression. So before I start, I want to just share a little bit about disclosures and some acknowledgements. So I am going to be talking about an intervention that I developed today, Interpersonal Psychotherapy-Adolescent Skills Training. And there is a book that we've written about the intervention, and so I do receive royalties for that book. I also do provide a lot of training and consultation in this prevention program, IPT-AST, as well as in interpersonal psychotherapy for depressed adolescents, which is another related treatment. As was mentioned before, I am going to briefly discuss some studies that have been funded by the National Institute of Mental Health and the Institute of Education Sciences, as well as an early study that was funded from the NARSAD Foundation. And most importantly, I really want to acknowledge that the work that I'm talking about today reflects not only my own work, but my work of my team, my collaborators. We have been so lucky to work with a number of wonderful schools and primary care partners, and an incredible number of adolescents and families who have participated in the studies that I'm going to talk about today. So the way that I'm going to spend time today is really to focus on 4 areas. I'm going to start by talking a little bit about why I think we need to be focusing more on prevention and really setting the stage for why I think depression, particularly during adolescence, is something that we need to be paying attention to. I'm then going to talk a little bit about the intervention, IPT-AST, this prevention program that I've delivered to give you a little bit of a flavor of what that intervention looks like. Talk briefly about why we've chosen to do a lot of that work in schools, and then spend the ending time really thinking about ways that we can expand the reach of prevention work. So starting with that first topic, depression is a really significant public health issue. It is the leading cause of disability worldwide. And this is not just adolescent depression, but depression across the lifespan. But when we focus in on adolescents specifically, we do know that teens who have adolescent depression, either at the symptom level, so even teens who have symptoms of depression, or teens who meet criteria for a diagnosis of depression, that those teens do experience significant impairment. That could be impairment in their school, impairment in their relationships. And we know that not only do they experience impairment, but it increases the risk for them to experience depression and other mental health problems in adulthood. And so sometimes when we talk about mental health disorders, we talk about it as if you either have or don't have a diagnosis. But what we know from the literature is that depression really happens on a continuum. And so even teens who have some symptoms of depression, but don't have enough symptoms to meet criteria for a diagnosis, do experience impairment. And that impairment is not that dissimilar from those who meet criteria for a diagnosis. And so I think that really is one of the first reasons that we want to be thinking not only about kids who meet criteria for diagnosis, but really those who have elevated symptoms. And unfortunately, current treatments, although there are many effective treatments for depression, they can only reduce about a third of the burden associated with depression. And there's a number of reasons for that. First of all, we know that depression is very common. It's a high incidence disorder, which means that lots of people are developing depression, unfortunately, on a daily basis. We know that many of those people take a long time to seek treatment, that it is difficult, unfortunately, to find treatment, whether that be medication or psychotherapy, that is evidence-based, and that even our best evidence-based treatments, medication, or psychotherapy don't necessarily work for everybody. So what we have existing is not sufficient to address this public health issue. One of the other things that we know is, unfortunately, that rates of depression really do surge in adolescence. And I'd like to set the stage for why I think that that's an important window for thinking about prevention. So this is a finding that is true across the literature, but this graph here shows some findings from a longitudinal risk factor study that I completed with my colleague Ben Henkin. And what we did in this study is we had 3 cohorts of youth. We had youth in 3rd grade, 6th grade, and 9th grade. And we followed each of those cohorts for 3 years. What that means is that we ended up having data on adolescents or children starting at age 8 all the way to age 17. And we followed these adolescents and did diagnostic evaluations with them every 6 months. And what we found is really what we see in the larger literature, that we see this increase in depression diagnoses around age 14. And that's also when we start to see this gender difference emerge, with girls being twice as likely to have a depression diagnosis than boys. And so we really do think, based on this data, that if we can intervene before that surge in depression, we may be able to have a good impact. So this was on depression diagnoses, but we also know that there's a considerable number of adolescents who have elevated symptoms. So these would be teens who either have elevated symptoms alone and would benefit from prevention, or potentially, if we did more of a diagnostic evaluation with them, might also benefit from treatment. And so this is some data from 4 school-based studies that we've conducted over the past 20 years. And the first 3 are completed studies. The last study is a study that we have ongoing now. And what we use in these studies to identify teens who have elevated symptoms of depression is the CESD, or the Center for Epidemiological Studies Depression Scale. And we use a score of 16 or higher, which has been used in literature to indicate teens with elevated symptoms. And what you'll see here is that, even in some of our early studies, we found somewhere between 20 to 40% of teens who met those criteria and had elevated symptoms. What you'll note here is in this most recent study, we're seeing a much larger increase in the number of teens who are endorsing these high scores. I do want to note that some of these data are from before the pandemic. So even pre-COVID, we were seeing these increases. But this certainly replicates what we're hearing in the news, that teens are definitely suffering more with the pandemic, and we're seeing that in our own data. So those data were from the schools. We also have data from CHOP, from Children's Hospital of Philadelphia. CHOP has a number of primary care practices. It has 31 practices. And like other primary care practices, we are screening for depression and adolescent well visits in line with the American Academy of Pediatrics, US Preventative Services Task Force recommendation that it's best practice at this point to screen teens for depression annually. And what we're seeing in that data, which uses a different measure known as the Patient Health Questionnaire 9, modified for adolescents, is that about 18% of teens have a score that suggests that they're experiencing some elevated symptoms. That would be a score between 5 and 10. And about 6% have a score greater than or equal to 11, which is indicative of more significant depression and potentially a depression diagnosis. So taken together, we know that there's this increase in teens who experience a diagnosis, and that there's an even larger number of kids who are experiencing symptoms and may benefit from an intervention. So just want to spend a second on some data that does not come from me, and this may be data that some of you have seen. There was a lot of publicity that came out when the CDC Youth Risk Behavior Survey findings were announced in February. And one of the reasons that there was a lot of attention to this is, this striking increase that we're seeing, particularly among females, of adolescent high school students who report persistent feelings of sadness or hopelessness. And you'll see here that there's been this really significant increase, particularly when we look at from 2017 to 2021. And these are some of the first national data from the pandemic. Really, again, noting that particularly for female students, it has been associated with this increase in sadness over time. So I feel like I've set the stage a little bit with a lot of bad news, and so I do very much want to spend the rest of the time focusing on some of the good news. And that is that depression is preventable. So there are several effective depression prevention programs. We're focusing today on adolescent programs and specifically on IPT-AST, but it is one of many programs. And these programs are delivered at other times in life. So there are programs for younger kids, there are programs for adults. And some meta-analyses that have been conducted by some well-known researchers have looked at these different prevention programs and have concluded that if these programs that already exist were more widely delivered, we could prevent anywhere from 22 to 38% of depression episodes. So I'd like you all to just think about that for a second. If we think of what that means 1 in 5, or even maybe 1 in 3 of episodes could be prevented if we took what we have already and we shared them more widely. When we think about some of the other public health initiatives that we do, or have done in the past, things like taking aspirin or exercising, those are less expensive for sure than delivering the type of intervention that I'm going to talk about today. But this type of impact and this type of reduction is really substantial. Not only could we prevent these episodes, but some cost analyses and modeling have shown that prevention programs are a particularly cost-effective way to reduce depression as compared to treatments and other models out there. So it's really something that we should be considering. So with that stage in mind, I want to talk in more detail about the program that I developed, IPT-AST. So Interpersonal Psychotherapy-Adolescent Skills Training is a predominantly group-based prevention program, and it's based on interpersonal psychotherapy. So my very close colleague and former mentor, Dr. Laura Mefson, was able to do a webinar a little while ago, focused specifically on the treatment, interpersonal psychotherapy for depressed adolescents. And this program very much comes from that and is based really on the very same idea that intervention is. And it's very simple. It's that we do not know what causes depression. And we also don't know what necessarily causes problems in our mood. But we do know that how we're feeling impacts how we act in our relationships, and problems in our relationships impact our mood. So again, just want you all to think a little bit about some examples from your day or your week or your life where that fits. So if I'm in a bad mood, I may be more irritable with my children. I may decide that I'm not really interested in going and spending time with my friends. If something happens in my relationships, for example, an argument with a colleague that impacts my mood and how I'm feeling, and that may in fact then impact how I react or treat other relationships. So it may have been my problem with my colleague that caused my bad mood, but then that bad mood may lead me to be more irritable with my children. So it's this very simple concept. And we teach this concept to the adolescents in the group because we very much want them to understand why we're going to spend the next 8 weeks really focusing on improving our relationships. Really with this idea that if we can improve our relationships and how we're functioning in our relationships, we have the potential to ideally prevent depression over time. So we are very much focused on teaching teens communication skills and interpersonal problem-solving skills that they can use to improve current relationships that they may be having, but also because this is a focus on prevention, we very much view these as life skills that we hope that can become part of their repertoire so that they can continue to use them beyond the group to address whatever relationship problems may come up in the future. So again, we are hoping that by teaching these skills and improving their relationships, we will ideally prevent them from developing depression over time. Much of the time when we're using this program, we are doing it with teens who have elevated depression symptoms. So all the data that I just shared on youth with symptoms are the type of kids that we've been enrolling in our groups. And so our goals are really to lower their current symptoms, and ideally we want to prevent them from developing depression over time. So that's the ultimate goal when we think about prevention programs. But we also recognize that kids are much more than their symptoms, and that it's very much important for them to be functioning in their overall life. And so we really do want to improve their functioning in addition to their symptoms. So we care about and measure how they're doing in school, how they're doing in their family, what are their friend relationships like, and what is their overall functioning over time. And then a really important goal for us that we don't get to talk about that often is that we recognize that for many teens, being involved in these programs is their first experience with any type of formal counseling intervention. So we try very much to make this group fun, for them to see that it's helpful, because we want them to feel like this is something that they can seek out in the future. We do know that kids who have elevated symptoms of depression are potentially likely to have depression in the future. And we very much hope that they can remember this intervention and will then go and seek help sooner. As I talked about before, one of the reasons why current treatments aren't sufficient is because it takes so long for people to seek help. And so we're hoping that if they've had this positive experience, they may be more likely to seek help sooner and therefore be able to address the symptoms or the depression that they're experiencing. So our program, as I said, is a predominantly group program. It's 8 group sessions. Those sessions typically happen weekly and are about 60 to 90 minutes, depending on the setting that we do. We do have some individual work that happens. So before the group starts, we see each teen for either 1 or 2 individual pre-group sessions. So if we have the ability to do a longer session, we might do 1 90-minute session or 75-minute session, or if we're in a setting that like a school, we might do that in 2 shorter sessions. We invite parents to attend to learn a little bit about the group. And then halfway through the group, we have another opportunity for some one-on-one time where each adolescent meets with the group leader one-on-one to really apply the skills that we've learned in session. And we again invite parents to attend. In the most recent couple of studies that we've done, we've also offered some individual booster sessions after group ends. This is a chance really for the adolescents to continue to apply the skills that they've learned, to get some individualized help focused on applying those skills to whatever relationship difficulties they may be experiencing right now. So when I think about IPT-AST, we think really about two main components. The first is education. So we do some defining of what we mean by prevention. And the best way we've done that is really by a metaphor. We brush our teeth because it can prevent cavities. That doesn't mean that if I brush my teeth every day, I will never get cavities, unfortunately. But it does mean that those people who brush their teeth are less likely to develop cavities than those who do not. And that's exactly what we say to the teens. Our hope is that by participating in this group and by utilizing these skills, you'd be less likely to develop depression than somebody else. But again, we can't fully prevent it, but that's the goal. We also are different, I think, than some of the other prevention programs out there in that we talk explicitly about what depression is and what the symptoms are. Many other prevention programs choose to kind of just talk about mood. They don't talk about depression specifically. But my feeling is that it's hard to prevent something if you don't know what you're trying to prevent, and that it's important to be aware of what your symptoms are. So again, you can seek help if you need them. So we do things like share scenarios of different types of adolescents and ask the teens to identify what the symptoms are, really helping them to recognize that depression looks different in each person, and also to make very clear that being sad is a normal emotion. So everybody experiences sadness, and many people experience other symptoms of depression, but that is normal. And then really trying to think about when we should be more concerned. And then finally, we provide some education again about this relationship that I've emphasized a lot between how we feel and our interpersonal interactions. And all of that education really sets the stage for the next part of the intervention, which is very much focused on interpersonal skill building. So we teach teens different communication and interpersonal strategies that I'm going to talk about in more detail. And we encourage them to apply those strategies first to hypothetical situations. So made up things that are pretty common and happen in adolescence, so they can get the experience on how to apply them in kind of safer situations. And then ultimately we ask them to apply those strategies to their own interpersonal problems and to address their own goals for the group. So I'm going to talk about the intervention in a little bit more detail, but want to be clear that I am doing this very briefly and recognizing that I have an audience of people who are mostly parents and not necessarily mental health providers. But I'm going to try to highlight in each section some things that I think might be particularly relevant. So in the pre-group session or sessions, the goal is really to begin to form a relationship with the teen and with the parent. So in most cases, this is somebody that you've met for the first time. So we want to have an opportunity one-on-one to get to know the teen, learn a little bit more about them, and get them comfortable with you as a group leader. We provide some of that education I talked about in terms of prevention, the interpersonal framework, and we also want to get them comfortable with the idea that we are going to be working together in a group. We always, in each of our sessions, assess the teen's depression symptoms, because again, we want to monitor their symptoms over time. And we also introduce a mood rating in this session, where we ask them to rate their mood, their average mood over the course of a week on a scale of 1 to 10. We ask for examples when their mood was better or worse, because we know that teenagers' moods fluctuate. And importantly, we try to get them to identify something that was happening in their relationships that may have impacted their mood in a positive or negative way. So if a teen reports that their mood was generally a 5, which would be average, but the time that they were better was when they were with friends and spending time with friends, we really want them to note that. Or if they report that their mood was much worse on a day because they got into an argument with a friend, again, we want to note that. We're going to spend time in the pre-group session conducting what we call an abbreviated interpersonal inventory. And the interpersonal inventory, which I'll talk about in more detail, is a core technique used in many interpersonal psychotherapy models, but we do a shorter version here. And we're doing that inventory to try to help the teen to learn about the teen's relationships. And then in doing that review of relationships, to help the teen identify some specific goals that they may have for group. And so I've listed different examples of goals here that would not be uncommon, but we're not just having a general goal, but really trying to make it very specific to what the teen shared. So it may be reducing conflict with their father or reducing conflict with their friend, Jami. So really trying to get specific based on the relationships that they've shared. When I talk about an interpersonal inventory, it's really a way of identifying the relationships that are most closely related, that first of all are that most important to the teen, and that are most closely related to either the onset or persistence of their depressive symptoms. And we use something called the closeness circle to get a better sense of the important people in the teen's life. So here's an example of a filled-in closeness circle. Jessica would be the teen that I'd be working with. And the way that I would describe it to Jessica is that I really want to understand the important characters or the important people in her life. The people in the circle closest to her are the people who are most important to her. These may be people who impact her mood in a positive or negative way, but they are the most important people in her life. The outer circle are people who are still really important. Maybe she doesn't feel as close to them, or maybe they have a different impact on her mood. And then the outermost circle are the people who she may feel less close to, or it may be that there's less of a positive relationship, but people who are still important for us to learn about. And so I go through in this way and then ask Jessica to fill the people in. So she would say, hey, my mom goes in that innermost circle. And then once I have a sense of this picture of the important people in her life, the reason we call it an abbreviated interpersonal inventory is because we don't have a lot of time in this one session or two sessions to go through details about each of these relationships. But we want to find out about the 4 or 5 relationships that we think are most important, or Jessica shares are most important. And we really want to understand aspects of that relationship. That might be what's working in that relationship, what's not working in that relationship. If it's a friend, how often they see the friend, how often they interact, what types of interactions do they have? Do they have arguments or areas of conflict? What are those about? And when they have arguments, how are those arguments resolved? Does somebody say they're sorry? Do people just walk away angry? What are some of the patterns of communication? So what can they talk to their mom about or their friend Brian about? What can't they talk about? How does that relationship impact their mood? And how, when they're in a bad mood, do they notice, if at all, that they're different in that relationship? So do I notice that I'm much more irritable and likely to pick an argument with my younger brother? And what are the desired changes that they'd like to make in the relationship? So if they could change the relationship, what would they like to change? And based on going through those relationships in that level of detail, we then, as I said on the slide before, ask the teen to identify and work with the teen to identify some goals for group. So again, that may be to reduce conflict with mom. That may be to spend more time with dad, who doesn't live at home, or to get closer to their friend Lisa, who is a new friend from school. And so we use this information in that pre-group session to really set the stage so that each adolescent in the group is going into the group with some specific goals that they would like to work on in the group. So then we have what we call our initial phase of group, which is our group sessions 1 to 3. And we try as much as we can to make these sessions as engaging and stress-free as possible. So we really want the group members to become comfortable with each other and with the group leader or leaders. We do some of that education that I was talking about depression. We provide that education that I was talking about in terms of the relationship between events and mood. And we use activities to really teach teens the importance of what we say and how we say it. And I'm going to explain in a second how we do that. And using that, we introduce something called communication analysis. And then we introduce these interpersonal strategies that we're going to be using in the rest of group. So in our session 2, we do a number of different activities. And the first activity is really intended to design that what we say and how we say it impacts how people interpret how we're feeling. And so we give teens these cue cards that look like this and ask everybody to say a statement in a certain way. And then we ask the rest of the group how we think that person is feeling and what about what they said or how they said it made us interpret that. So here's an example. I'm fine. Nothing's wrong. Really, I'm fine. Now, any of you who have teens, and I do, might be thinking, is this person fine? Or is this person just trying to get me to stop talking to them? And so we have a conversation. The words suggest the teen is fine, but there's something about the way I delivered it and something about the way that we've just heard I'm fine too many times that we think it might mean something else. And then we have the next person go and do the next example. And again, we're trying to get everybody engaged in the group. We're laughing a little bit. They love to see me as a group leader say something really obnoxious and act like an obnoxious teenager. But it really does emphasize this idea again of what we say and how we say it impacts what people think we're feeling. The next example and the next activity is really intended to demonstrate that not only what we say and how we say it impacts how the other person thinks we're feeling, but it also impacts how the other person responds. And so again, we have these hypothetical situations that are not uncommon to these teens, but are not personal. And we ask them to act them out, and we act them out as a group. And again, they have a lot of fun when I get to act like a teenager. And we have a conversation, and we encourage them in this first activity to not worry about saying things correctly, and in fact, to be dramatic because it's more fun to see how it works out. And then we start to go back after they've done this role play and have had this conversation to then break it apart in more detail, to understand what was said and who said what when, to really begin to think about this idea that we can dissect a communication into different pieces and figure out who said what. So we started the conversation. I was playing the teen. Does anyone remember what I said? I said, I can't believe you're not letting me go to that party. Okay, does anyone remember what parents said back? Of course I'm not letting you go to that party. Why would I let you go to that party? How do you think parent was feeling when they said that? Does anyone remember what teen said? Teen, how are you feeling when that happened? And so we're really breaking down the conversation to get them to understand the feelings that generated the interaction, what feelings they conveyed, either verbally or non-verbally, talking about how the communication ended and what the impact was, and getting them to begin to think about the idea that if we could change the communication, even one small part of the communication, we may change the impact of the conversation. So as we're going through those initial communication analyses and role plays, we're really just, again, trying to emphasize that we have some ability to change how a conversation goes by changing a very small part of it. And this is a great way also for the teens to get very involved. And we have a lot of fun in this particular session. So after we've taught them this concept, in session 3 is really when we start to teach them these communication strategies. And these communication strategies are not rocket science. They're fairly basic, and they are not inclusive, entirely inclusive. There are plenty of other communication strategies that may be helpful in a particular situation. But I'm just going to spend a minute or two explaining these techniques, because these are techniques that can be very helpful in your own relationships, and certainly when you're interacting with your children. So the first is really to strike while the iron is cold. And this is really about helping the teen think about the right time and the best time to have a conversation. We all have examples in our own life when we've said things we've regretted when we're angry. And so this is really trying to find a time where the teen is calm, where the other person is calm, And some of that can be actually asking if now is a good time to talk, and then introducing the topic in a calm way. We teach about I statements, so really using statements that express how you're feeling about something rather than blaming the other person. And we know that I statements are really hard, particularly for adolescents. It's something we teach kids for a long time, but I think in adolescents in particular, they feel really vulnerable expressing how they feel. So this is probably the one that takes the most effort to get the teens to buy in. But really this idea that if I can express my feelings, it's very difficult for the other person to argue about it. And that while this feels vulnerable, it can really be a sense of strength. So I was upset or I feel sad when can be very powerful, especially when expressed to people who care about how you're feeling. We encourage them to be specific in their conversation and to avoid things like you always or you never, or avoid bringing up things that happened a long time ago. Again, we can all think about examples in our life where somebody has brought up something that happened a year ago or 3 months ago, and it just makes us pretty angry. So we really want to try to be specific. You know, Mom, I'd like to talk to you about the argument we had last week about my grades. Not, Mom, you always tell me that my grades are awful. We encourage them to put themselves in the other person's shoes. So this is not just having empathy, which is really important, but actually communicating to the other person that you understand their point of view. So Mom, I know you're really disappointed in my grades because you want me to do well. That sets the stage for a much calmer conversation and really can diffuse the situation. We encourage them to have solutions in mind before they go into a conversation, and to remember to ask the other person if the other person has any good ideas, and to be willing to compromise. So if you're having an argument because your parent won't let you go to a party, if you go into the conversation with some solutions, maybe I can go and get back at 9 o'clock. Maybe I can go with a group of people. Maybe my older sibling can take me. Maybe I can FaceTime you when I got there so you know that I'm safe. And recognizing that none of those may be exactly what the teen wants, but to be willing to compromise because it may be better than what they would have gotten otherwise. And then lastly, we teach them not to give up. And this is not to keep fighting and having a conversation when it's really heated, but recognizing that although these skills are really basic, they feel kind of awkward and clunky when you first try them. And that some relationship problems, or most relationship problems, are not resolved in one conversation. And so we need to not give up, to find another time to have a conversation. And it may be that we need to change some of our strategies a little bit in our approach, but that if we follow up and continue, that we may have more success over time. So we teach these skills to the teens. And first we ask them to apply those to those same types of hypothetical situations I just showed you on the cue cards. And then as they get more comfortable, as I said, we get to have them begin to work on that on their own interpersonal relationships. And that's really what we do in the latter half of the group. So thinking about kind of sessions 4 to 6 or 7, is we ask teens to bring in situations that are happening in their lives. They come in, they report on their mood, something that's been happening in their relationships. And then we ask them to apply those strategies and interpersonal problem solving more broadly to the situations that they bring in. So if somebody comes in and says that they had an argument with their friend, we may use communication analysis to understand that interaction, to really understand who said what and what we might want to change or what we might need to think about in the process to inform the next conversation that they may have. We get them to practice applying those strategies using role plays. So again, we want to make sure that they have the experience of applying the skills, and I'll talk a little bit more about what that looks like. We very much want them to take what we're doing in group and take it to their own relationships outside of group. So talking about it is great, but going and having the conversation with their friend that they planned is really where we see the key to success. And so we assign them interpersonal work at home. And when they've had those successes, We also do very much link any changes that have happened in their relationships to changes in their depressant symptoms, because again, each week they're filling out a checklist on how their symptoms are and their mood rating over time. So when we think about applying these skills to a specific conversation, we really do a fair amount of scripting or preparatory work before we go into a role play. So we very much want to lead with the goal of the teen's goal for the conversation. So without worrying about how to say it, what would you want to convey? So if I've had an argument with my friend has been spreading rumors about me, I want to have a conversation. I need to ask the teen, what is their goal of the conversation first? And then when we think about, given that goal, how can we say that in a way that's most likely to have a positive outcome? And might the strategies be helpful? Sometimes not all the strategies apply. Sometimes we need to apply certain strategies again and again. Sometimes we need to ask questions that have nothing to do with the strategies, but the strategies can often be helpful. And we very much want them to think about how might they start the conversation. We want to anticipate, based on their experience with that particular person, how might that person respond? What can we say next? And we always want to help them think about how might they end the conversation, both if it's going well or not going well. We know that teens often, when they're upset, kind of huff off and walk away. And so we want them to be able to articulate, you know what, the iron's not cold right now. I need a break. We can talk about this later. Or if it's going well, to acknowledge it and to think about how to end it. And that really allows us to figure out the first few statements to prepare the teen for the role play that we'll then do in the group, and then to have the conversation in real life. So after we've scripted this, we would then role play it. We'd ask the teen to play themselves. We'd ask one of the group members to play the friend. We'd assign somebody, a coach, who can help remind the teen what skills to use. And that really gives them the preparation and hopefully the courage to have this conversation outside of group. And then ideally in the next group session, they would come back and tell us how it went. And if we needed to, we could think about next steps. So the mid-group session, again, is this individual session that occurs after group session 4 or 5. Parents are invited to attend. And this opportunity in this mid-group session is really to talk one-on-one with how the adolescent feels about group, to remind them of the goals that they identified in their individual sessions, and then to do some work on the goals, either with the adolescent alone or with the adolescent and parent. And this can be a really powerful way for the leader to help provide some coaching to the teen as they're talking to their parent. And it's also a great way for us to teach the skills that I've just described to you to the parents, and then really to encourage the teen to continue their interpersonal work. And then in the last couple of sessions, we really spend time starting to think about their progress that they made, thinking about which strategies they liked and which ones were most challenging. They do not all like all of them. Sometimes they don't like any of them, but we really try to think about those ones that are more challenging and how to overcome some of the barriers to utilizing the skills. We really want to emphasize, again, that they've had these conversations outside of group. We want to talk about how they felt being in the group and how they feel about it ending. And then we do, because we know that this is prevention, we do talk to them about what signs do they want to pay attention to individually that might indicate that their symptoms are getting worse, and that they may need some type of services. So we really talk about, like, what is their own individual check engine light that they want to pay attention to think about what they can do to improve their mood, to solve an interpersonal problem, or potentially to seek treatment. And then we assess the need for further intervention. And if we are going to offer booster sessions, we do talk about those booster sessions in this phase so they know that they can access that. So now that you have a little bit of a flavor about what this program is, I want to talk a little bit about the work we've done in schools and why we've chosen to do that work in schools. So schools are really a really great place for delivering prevention program for a number of reasons. First of all, We know from the larger literature that this is where most youth receive mental health services. So there are great access problems, unfortunately, in terms of receiving care. And when teens do receive care, a good percentage of them just get those in schools. We know that school-based programs can be less stigmatizing, so it's easier and more comfortable to access care. For prevention, it's really important because it provides an opportunity to target problems early. It'd be very difficult to do prevention in a mental health clinic because most of the people who are coming to a mental health clinic already have a diagnosis. And so we're not able to do early intervention. And we also know that schools promote access to care for underserved populations, including minority youth. So there's lots of benefits of school-based interventions. Unfortunately, there hasn't been as much uptake or use of evidence-based interventions by school counselors and other school providers. And so there's definitely an interest in thinking about how can we train school-based providers to deliver interventions that have been backed by research. So I spent much of my life working in schools, as is evident by some of the screening data I presented before. And so when I shared that we had 3 completed IPT-AST studies in schools, here's some of the data from those studies. So in the first 2 studies, which took place in New York, Washington Heights, and the Bronx, we compared our program to usual counseling with either a school counselor or social worker. In the 3rd study, which was a much larger study and took place in New Jersey and happened in the public schools in New Jersey, we compared IPT-AST to what we considered enhanced group counseling. And what that means is that we asked the counselors in the schools to choose to run a group that had, similar to IPT-AST, 8 group sessions. They could do an open-ended group if they wanted, or they could choose one of the existing manuals that exist with other evidence-based interventions, and many of them did. And what we found, and this is a summary of lots and lots of years of research across many different studies, but that IPT-AST is more effective at decreasing depressive symptoms. In 2 of the 3 studies, we found that kids who participated in IPT-AST were less likely to develop a depression diagnosis in the 6 months to year after the program. We've seen improvements in overall functioning. We've seen decreases in parent-child conflict, which is really exciting for us because that's one of the things we spend a fair amount of time focused on. We are excited to see that not only do we see effects on depression symptoms, but also on anxiety symptoms. And sometimes together people call depression and anxiety internalizing symptoms. We see improvements in social functioning, improvements in school functioning. And in these studies, we're seeing effects to about 6 months to a year post-intervention. And I just want to be clear that we see lots of positive effects, but the long-term effects of this program after a year, as well as other depression prevention programs, are really not as robust as we would like. Ideally, we would love prevention programs that have much longer effects, and we'd like our effects to be even bigger than they are. So the work I just discussed were all for kids who had elevated symptoms of depression, which is also known as indicated prevention. IPT-AST has also been tested in schools in one universal sample. When I think about universal sample, this is for kids who all receive the intervention, regardless of whether they have elevated symptoms of depression or regardless of whether they have other risks for depression. And this was a study that was conducted at Vanderbilt, where they compared a modified version of the program that I've talked about today, didn't have any of the individual sessions, something called Coping with Stress, which is a cognitive prevention program developed by Greg Clark, which has lots of evidence of great efficacy. And then they compared a group of kids who received nothing, and they focused on kids in 9th grade. And this was instead of their wellness or health class. And what they found is that youth who received either IPT-AST or CWS had fewer depressive symptoms at post-intervention than those kids who had no intervention. But they didn't see in this universal sample those effects persist at 6-month follow-up. And then, like many universal prevention studies, they looked at kids who had elevated symptoms and found that the benefits of the programs were even more pronounced at that point. So one of the problems with depression prevention programs, particularly in schools, but throughout, is that kids don't show up. And I just want to briefly say that that is really not the case in our IPT-AST studies. So again, we have 8 group sessions, some individual sessions. It differs a little bit in the study, but you can see that on average, teens are attending somewhere between 5 and 7 of the group sessions. So attendance has been very good, which we think really speaks to the appeal of IPT-AST to adolescents and the feasibility of running these groups in schools. And I do want to note that we haven't noted significant differences in attendance, whether we do it during the school day, where obviously kids are a captive audience, but even after school, our attendance has been very good. We also see high satisfaction with the program. Teens really like the program, and we think that that's probably why they keep coming. And I also want to note that in that 3rd study, we also asked how they felt about the other groups that counselors were running, and they also really liked those and thought that they were helpful. So we again think that this further speaks to the appeal of IPT-AST and to prevention groups more broadly. So here's some feedback that comes specifically from teens, parents, and counselors, really emphasizing some of what they experienced being in the group in the case of teens, or what they noticed in the case of parents or counselors. So just I'll let you look at that very quickly before we move on beyond that. So I just want to briefly mention our current study, which is the study that I talked briefly about, where we see these higher elevations of depression. This is funded by the Institute of Education Sciences. This project changed over the course of COVID, and we redesigned the project when COVID hit, so that we could continue to deliver this prevention program when schools were shut down. And what we did is we decided to change the design to really look at whether this program was effective and had the same level of effectiveness that we had seen in prior studies when we delivered it through telehealth. So the past 3 years, we've taken this intervention and have done groups on Zoom or a similar platform to really look to see whether we see any benefits of the program when delivered remotely. And again, we're going to be looking at social, emotional, and school-related outcomes. So I want to spend the last couple of minutes briefly just talking about ways we can expand the reach of prevention. So I talked a lot about how we have these effective prevention programs, but their effects are good. They may not last quite as long as we would like. So one way to potentially enhance the impact of prevention programs is to think more critically about what program may be most beneficial for a given adolescent. So our program is really focused on interpersonal risks. I've just talked about that a lot. It may be most beneficial for teens who have interpersonal risks for depression, who maybe have challenges in their relationships, high conflict, or low support from their friends or family, because we're really addressing that specific need. Cognitive behavioral prevention programs, something like coping with stress, may be particularly relevant for teens who have more cognitive risks for depression. That may be kids who are experiencing things like thoughts like, this is all my fault, or things will always be bad, because this intervention really teaches kids to challenge those cognitive risks for depression. And so we looked at this question in our most recent study, which is known as the Personalized Depression Prevention Study. And we actually classified kids as having either interpersonal or cognitive risks for depression. And then we gave them either IPT-AST or coping with stress, CWS. And so some kids got a matched intervention. So an example of a matched intervention would be a teen who reports high interpersonal risk who got IPT-AST, or teens who have high cognitive risks who get coping with stress. And a mismatch would be if that teen with high cognitive risks got our program, which is more interpersonally focused. And what we found is that teens who received a matched intervention had greater decreases in both their depression and anxiety symptoms than those who received a mismatched program. And interestingly, or importantly, those results persisted all the way till 18 months after the intervention. So we're seeing some evidence of lengthening the effects of the program by doing this. And I just want to note that these are two very strong evidence-based program. We were not trying to figure out what program worked better, but what program worked better for whom. And importantly, when we looked at diagnoses, we saw a benefit of matching, but it was specific to those teens in high interpersonal risk. Adolescents with high interpersonal risk who received IPT-AST had a 62% reduction in depression diagnoses as compared to those kids with high interpersonal risk who received CWS. So if you remember when I started, I said that something like 22 to 31% of diagnoses could be prevented in those meta-analyses. We basically doubled that reduction rate by giving teens intervention that matched their risks. So this is one way of potentially enhancing the reach of prevention. Another way to do that is really to expand to other settings. We think that primary care is another important setting to increase access to care. We know that teens are now increasingly being screened for depression as part of their well visits, and that can enable us to then provide prevention to those kids. And we have conducted some pilot work where we've delivered IPT-AST in primary care, and we have found similarly good attendance, even though they're coming to their primary care office, and similarly high levels of satisfaction. And we're starting to see, we saw some preliminary evidence that it also works effectively in this setting. And I encourage us to be thinking about other settings that we should be considering. There are some great online digital prevention programs that are worth exploring, and then thinking about other settings we could provide an intervention like IPT-AST. And the last way I think that we should be thinking about increasing access to prevention is really how do we implement and fund these programs across settings. So I've hopefully argued that prevention is necessary and that prevention can be effective. The challenge is that our current reimbursement models don't allow us to get reimbursed for prevention. They typically require for you to have a mental health diagnosis to get that to be reimbursed. We're seeing some really nice solutions being explored in a couple of states. So in 2018, Colorado's Medicaid agency allowed for 6 sessions to be delivered in primary care without a diagnosis. And most recently, Massachusetts also enabled reimbursement for preventive services. And they did that specifically for kids who had a positive behavioral health screen. So again, going to your doctor's office and having that PHQ-9, who then don't meet criteria for a diagnosis. And so we're really excited that other innovative funding solutions are being pursued in other states. So I hope by thinking about these different ways of enhancing the impact of prevention, that maybe by providing a specific prevention program to a specific teen, expanding the settings in which we deliver these services, and very much thinking about how do we fund these programs, that we can enhance the reach of prevention and hopefully prevent depression amongst more adolescents. And with that, I'm going to stop. I am happy to stop sharing and answer any questions that have come up.
Thank you so much, Dr. Yang, for the wonderful presentation. Okay, now we are open up to Q&A session. Let me ask the first question. Might the relationship of a girl to boy ratio have changed since the study in 2015? This question was raised at the early presentation.
So the consistent, from a diagnostic standpoint, there has always been for a long time a greater ratio of girls than boys who meet criteria for a depression diagnosis. Typically, it's been about 2 to 1 starting in adolescence. That is not the case in younger children. So in younger children, boys and girls have similar rates of diagnoses, but starting in adolescence is really where we start to see that divergence. Specific to symptoms, we've again also always seen that girls report more symptoms than boys. That's been consistent. But that CDC finding is really where we're starting to see a specific impact of COVID potentially, but other things on girls in a different way than we're seeing it on boys.
Okay, next question. Once you see depression, are there any indicators that would show increased risk for suicide?
Yes, I mean, I think there's lots of risk factors for suicide, depression being one of them, but there are unfortunately many individuals who contemplate suicide who are not necessarily depressed. But some of those risk factors for depression and suicide are similar. So thinking again about some of those cognitive risks that I talked about, thinking like things are never going to get better. And we do also know that for some kids who are contemplating suicide, that there is often an interpersonal precipitant before that. I mean, I think our biggest indicator for which kids are at risk with depression are really those kids who are experiencing suicidal thoughts, who have a prior history of making a suicide attempt. And we are also increasingly seeing that kids who do engage in non-suicidal self-injury along with suicidal thoughts are at increased risk for suicide.
Okay. Next question, does IPT-AST take cultural differences into consideration?
Such a great question. Yes, we do that as much as we can. And we really do that when we're thinking about scripting in particular, because we're asking them to plan the conversation as they would have it with the person in their life. So we are not just saying, how would a random parent respond, but how would your parent, who may be of Chinese background, respond? And what would be appropriate to say or not appropriate to say, and how would that be viewed? Obviously, we have kids of all different cultural and racial and ethnic backgrounds in our group, but we are trying to be really cognizant of getting them to think about, again, for their particular parent or their particular cultural background, what would feel okay or not. It has also been, utilized in different cultures and in different countries, and we're very thoughtful when we do trainings or train people for them to give us feedback, again, of how something may sound in a different language or in a different culture. So I do think that there probably need to be some cultural modifications as this goes out into other places, but we have done this in other countries as well.
Oh, okay, great. Next question probably for us, will the slide be available and when will the recording be available? So this presentation has been recorded and we will upload the recordings into allenhu-foundation.org website later and also upload into a YouTube channel. So please subscribe, youtube.com/allenhu-foundation. And you will receive an automatic notification when we upload the video. Okay. So next question, how can we best encourage our teens to attend this type of sessions if they are reluctant?
So such a good question. I think if we can try to get them to come to that first group or two to try it out, we typically get them to stick. So we are hopeful, and we do purposefully have this one-on-one session first because it can be really intimidating to join a group, particularly in some cases to join a group with other people from their school without knowing who's going to be coming into that group session. And so we do try to break the ice by having those individual sessions. And then typically, again, if I can get somebody to come to that first or second group session, then usually they stick. For some kids, group is just a lot for them to do, and they may be better off one-on-one, either because they're pretty shy or reticent, or because they have something to talk about that they just really wouldn't be comfortable talking about in a group setting. And so we have found that there are some kids who aren't interested in doing it. I do like to specify that it is fun, and kids do say they have a lot of fun. We laugh. They're very, very supportive of each other. And so I think that when I try to sell that based on other people's experiences, sometimes that makes the teens more likely to go.
All right. Next question, were the attendees in the sessions randomly selected or did they know each other?
Great question. So in all of our studies, when we've done stuff in schools, kids are randomly assigned to either be in our group or to get the other condition. In some of our schools, the kids know each other because they're small. In some of the schools, they don't know each other at all. And we don't share who's in the group until the group starts because we want to respect that somebody may choose not to participate, and we take confidentiality really, really seriously. So we set up some rules to make the kids feel more comfortable talking in group, and they develop the rules themselves. So that rule may be in a school setting that I'm not going to use somebody's real name, when I'm talking about somebody that other people may know, so that we're not breaking anybody's confidentiality and so that people feel comfortable talking about it. We've had people who were good friends who came to group. We've had kids who are not friends at all. We've had romantic relationships break up during our groups. So we've kind of handled a little bit of everything. But we really want to try to make sure the group feels like a safe space. So if we know that there's a really conflictual relationship, in particular bullying or something like that, we would not want those kids to be in the same group. But other than that, it's random who's in the group.
Okay. So were the sessions during or after school hours?
Great question. So it differed a little bit. And in that attendance information I provided, I tried to specify whether the groups were during the school day or afterwards. In most of the groups, in many of the schools, it's after school. But in some of the schools, we've been able to flexibly do it during the school day. It's great if we can do it during the school day, because we are then not competing with all the after school activities that happen. But we also are very respectful and do it after school. And we have found that kids do attend even when it's after school. It can just be a little bit difficult to schedule a group that works for everybody.
Okay. And can the sessions be delivered virtually as well as in person?
Yes. So in this most recent study, we've been doing it all through something like this on Zoom. We have made some small changes to make that work a little bit better. I would say the feedback we've gotten so far from the kids, some like it, some very much want to be back together in person. It does enable us, by doing it this way, to allow us to handle kids from multiple different schools in one group. So that's been a benefit, and we'll really look to see whether we see the same benefits when we do it by group. We're still looking at that, and we're also getting feedback from adolescents themselves about how they feel about doing it through telehealth. I think everybody's a little sick of Zoom after COVID.
Yeah. Okay. Dr. Young, we probably need to wrap up at the 6:10 because we are a little bit over. So maybe 2 to 3 questions more. Okay. Okay. And what are the symptoms of adolescent depression? Can they present in different ways?
Yes, absolutely. So just like adult depression, one person with depression can look very different than another person with depression. First of all, in adolescents, one of the most striking difference as compared to adults is that some teens really experience more irritability than sad mood. And so that's one very substantial difference from adults. But again, if you have symptoms of depression, you could have difficulties falling asleep, but other people may have challenges where they want to sleep all the time. You could have difficulties where you've lost your appetite, but other people with depression may feel like all they want to do is eat. So there are different symptoms, and no two people with depression experience them in exactly the same way.
Okay. Could you explain how you assess the effectiveness of IPT-AST? Is there a specific measure that you use?
Great question. We use lots and lots of measures. So we don't look at any one indicator. So we do a diagnostic interview to assess depression diagnoses. We have teens fill out forms about depression and anxiety. We're collecting school-related data. So we're actually getting data from schools about people's attendance and disciplinary incidents and grades. We get data from parents. So we don't just ask a kid how their relationship with their parent is going. We ask parents how their relationship with their kid is going. So we do it in a number of different ways. And so it is not one specific way that we assess the outcomes. Okay.
How about last question? How can I get my teen into one of these programs? Is it still a study phase, or is it generally available?
It's a great question, and I'm seeing some questions to me directly too. So the program is available widely. So again, the book is there, and I wrote the book not to make money, but actually for counselors in schools to be able to deliver the program to people in schools and other settings. It's listed on a registry of evidence-based programs at this point, and so there are opportunities for people to get trained if they're interested in delivering the program and then delivering the program in their local settings. We are not offering it largely to everybody at this point, mostly because most of my time is spent still developing and testing it, and then the rest of my day job. So at this point, with me specifically, we're only offering this for teens who enrolled in the schools that we're focused with. But there are places, as I said, that are starting to implement this. We recently did a training, for instance, in Colorado for a number of school counselors. So we're hoping that this program and other ones like it are more readily available. And again, I've talked about IPT-AST, but I want to be clear, there are a number of other really great programs out there that may be easier to access wherever you may be.
Okay, great. Thank you so much, Dr. Young, for the wonderful presentation and the Q&A. And also thanks everyone for joining our webinar. We're going to wrap up this event. We hope to see you again on May 31st for a webinar with Dr. Princeton and Dr. Teltzer on the topic about social media and the youth mental health. And please take a moment to fill out a short survey. I will leave the donation QR code for a few more minutes. And thank you for donating to support mental health. With that, I'm closing the webinar. And thank you, Dr. Young. And thanks, everyone.
Have a good
Goodbye
night.
and take care and stay well.